Is that okay, Professor Kato?
Yes.
Is that okay? Can we start the webinar?
Yes, I think so. We can start.
Okay. So, good morning, good afternoon, good evening from all neurosurgeons around the world. So I'm so happy to see you. And this again is the ACNS YNS webinars, and we are so happy to see you all again. So our here today is Professor Nathaniel Ben-Salom, who is the Assistant Professor of Neurosurgery of Donald and Barbara Zucker's School of Medicine at Hofstra Lofgau. He's also the co-founder of the Neuroplastic and Reconstructive Program in Lenox-Hill Hospital Neurosurgical Oncology in Lenox-Hill Hospital in New York, USA. Our speakers, we have 3 speakers today. Our first expert speaker is Professor 𝒂𝒏𝒔, who is the professor and head of Department of Neurosurgery, Government Park Medical College in Chennai, India. His topic today is a call for a new subspecialty in Asian continent neuroplastic surgeries. Our second YNS speaker is Professor Xu Xinhua, who is the Associate Chief Physician of the Department of Neurosurgery of the First Medical Center of China PLA General Hospital in China. This topic today is a surgical resection combined with intraoperative radiotherapy for the treatment of brain metastasis. Our first speaker is Professor Timo Klings. Professor Timo Klings is the professor and chief of the Neurovascular Center in 𝒂𝒏𝒔 Hospital in Boston, USA. His topic today is vessel wall imaging in brain AVMs. Our professional discussant today is we have Professor 𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂 and President of Ukrainian Association of Neurosurgeons and Associate Professor of Department of Neurosurgery in 𝒂𝒏𝒔 National Healthcare University. Our second discussant today is Professor Ahmed Issa. He is the Professor of Kabul University of Medical Centers, KUMS, Chief of Neurosurgery Department of the 𝒂𝒑 University Hospital. He is also the President of the Afghanistan Neurosurgical Society. To moderate the sessions alongside with me, Dr. Teek, Dr. Hilfam, and Dr. Sam, and Dr. Biswa. So may I invite our chair today, Professor Ben Saloom, to introduce our first speaker. Thank you, Professor Ben Saloom.
Thank you so much, Professor Ben, for this beautiful introduction, and thank you for having me. This is a really exciting time. This is 6 a.m. Sunday morning in New York, and we're having guests from all over the world. So I can't wait to listen to each and every one of you. And I would like to introduce this first speaker, which I'm very much waiting for the presentation, Professor Marapan, which is going to talk about the call for new subspecialty in Asian continent, neuroplastic surgery, which is something that is very close to and dear to my heart, and I cannot wait to see where this goes and to see this flourishing collaboration across the world.
Thank you, Dr. Ben. Shall I share my screen?
Yes.
Yes, please go ahead.
Good evening, everyone. First of all, I would like to thank our Honorable Professor 𝒂𝒂𝒏 ma'am and Dr. Liu for organizing this wonderful webinars on behalf of ACNS. So it's a very good platform to connect all the neurosurgeons in Asia and also around the world. Thank you, ma'am, for this creating wonderful platform for this joint discussions and exchanging our ideas. And again, I would like to thank Dr. Ben. I invited him because we are traveling in the same path for some time. And recently I got introduced him based upon our publication in Neurosurgical Review. So thank you, Dr. Ben, joining us in the early morning. So we are in India now in the evening. So good evening from India to everyone. So now I'm going to talk about a call for a new neurosurgical subspecialty in Asian continent, that is neuroplastic surgery. So it is a passionate field. Actually, accidentally, I started this practice almost 15 years ago. I don't know it was neuroplastic surgery when I started this practice. It was accidentally happened, and I started doing with my colleagues. my colleagues, Dr. Preeti Uday, she was an oculoplasty surgeon, and Dr. Anand, he was a 𝒂𝒐𝒏𝒂𝒂, and also Dr. Girish Ambat is a plastic surgeon. So the journey was exciting. What is the importance of neuroplastic surgery? It is a demanding field. Neurosurgeons are doing cosmetic neurosurgery. So in this field, we are not reshaping the patient, and also we are improving the self-confidence and emotional well-being of the patient. And in this field, we are making some meaningful change to somebody's life. Now, I'm classifying this Department of Neuroplastic Surgery in super specialty of neurosurgery as 4 or 5 divisions. One is complex head trauma. Second one is spinal dysraphism. Third one is developmental disorders like craniosynostosis. And fourth is scalp and skull tumor reconstruction. And fifth is I'm adding as bed sores also. Because all these areas in neurosurgical practice need neuroplastic surgery. If you see a patient like this, who's having a very complex head trauma, who's having a head injury, orbital injury, facial injury, dental injury, when I was doing my residency, these patients are directly transferred to neurosurgical department. What will happen? We'll address the neurosurgical problem. The left of orbital, facial, dental injuries are not addressed properly. So the cosmetic effects will be very bad, and it was neglected to all complex head trauma patients. Second important area is spinal dysraphism. This is a newborn child with open spinal neural tube defect. If it is not addressed properly, it will lead to major complications like CSF leaks and also fatal meningitis and all in spinal dysraphism. This is another area, it's a developmental disorder of craniosynostosis, where the sutures are closing prematurely. It is also a need of great support of neuroplastic work. This is another complex subject in neuroplastic surgery. This is a guy who was a fitness trainer. He had a orbitofrontal tumor, was operated twice elsewhere, and it was not removed completely because of the location. And he had a very bad cosmetic defect on the head. He used to grow his hair like a saint to cover the defect. So this was affecting his daily day-to-day activity and his mental thinking and complexity. So he was almost like depressed for so long time. So this area needs the work of neuroplastic surgery. Now I'm going to share a few of my experience in the past 2 decades of my neuroplastic work. So the patients with the complex head injuries, they are given importance for saving life, not for cosmetic problems. It lead to major skull defects and deformities. This is one of my initial patient, almost in 2010. He had a very complex frontal, orbital, nasal, and facial fracture. So that time, the hospital where I was practicing was a plastic surgeon was almost available all the time. And we called a oculoplasty surgeon and the 𝒂𝒐𝒏𝒂𝒂 surgeon. We did primary correction of the defect. So the cranial part was done by me, and the nasal part was done by the 𝒂𝒑𝒏𝒂𝒂, and ocular part was done by oculoplastic fellow. And finally, the skin work was done by plastic team. So this is a very shattered face, which has very complex fronto-orbitofacial injury. This was very primitive implants made up of titanium, which I was using almost 15 years ago. The frontal part was corrected by me, and all the rest of work by my colleagues. So this is the patient immediately after surgery. This is almost after 6 months. So almost we are given some good cosmetic result to the patient with a team of 3-4 specialties. In pediatric age group, the complex spinal dysraphism like lipomyelomyomenigosis is very difficult to treat by neurosurgeons alone because the defect should be addressed properly. If the defects were not properly addressed, the repair was not properly done, definitely they'll end up in CSF leaks. That too, the skin was very fragile in newborns and young age group babies. This is one of our patients who had a spinal dysraphism with myelocele, and this was having a very huge defect in the back, and the patient was planned properly with the flap cover, and we excised the sac in total, and the dura was repaired, and the defect was corrected, and the excess skin was excised. Now the patient was given very good cosmetic result, because in female children that was a very bad cosmetic appearance if it is not treated properly. This craniosynostosis I already mentioned. The patient's metopic sutures and sagittal suture were closed very prematurely, and the coronal suture was also closed partially. So we did a simple strip craniectomy, and it was given very good cosmetic result to the baby. And also it prevented so many complications in the future. So in our hospital, so we are addressing almost very complex trauma like fronto-orbitofacial deformities. So we started doing 3D reconstruction. So this is one of the patient who had very severe head injury with the bilateral skull defects. So we did 3D planning for the patient, and the patient-specific implant was designed. That was printed in titanium. The skull defect was corrected with 3D patient-specific implant. One of the good news in this treatment in our hospital, this treatment was entirely covered by the government insurance scheme, and it is totally free of cost to the patient. So this is one of our healthcare delivery model in Tamil Nadu, southern part of India. The entire high-end neuroplastic work is done free of cost. So this is the patient. The implant was designed and printed. This is in post-op period. Both side head was corrected with beautiful patient-specific implant. This is another fellow, young guy who had a complex head trauma with fronto-orbital defect. This was also planned with patient-specific implant. This time we used mirroring method. So this is the defect without implant. This is with 3D implant. This is the model. This is the intra period. So we did mirroring corresponding to the right side. This happened on left side. So this is the defect. The defect was elevated, and the proper mesh was planned according to the right side. This is the post-op effect. So it has given a very good cosmetic result to him. This is a very bad complex disease. This child actually, she came to us when she was 5. Now she is almost 13 or 14. She had a recurrent neurofibroma in the orbit, which was extending to the skull base. The tumor was shifting her entire eyeball. Almost the eyeball was depressed, and it was shifted down and made laterally. The mass was protruding through the eyelid. The skin was very lax, friable. She was operated twice elsewhere. So this is the tumor which was seen around the orbit. Luckily, she had partial vision in that eye. So we were trying to preserve the vision which was having. And my oculoplasty team, Dr. Preeti, was doing an excellent job. I opened from the top. This, you can see the multiple scars which was operated previously. So this was almost done almost 10 years back. That time we were using only, there was no 3D printed mesh that time. So this is a cranioplasty mesh which was almost manually designed according to the roof of the orbit, and also the orbital rim was designed. This is the area where I did my work. This is my oculoplasty fellow who did this work. She excised the tumor from the down. I excised the tumor from the top. The tumor was totally excised. Now, after that, the mesh was placed in the defect area in the skull, and also roof was repaired. So this is the tumor. This is the post-op period. So the rim was beautifully reconstructed. The tumor was excised in total. The mass was nothing inside the orbit, although now she is in follow-up for more than 10 years. Now she is doing good. Now we can see the tumor was totally, this was skin which was almost become a very fragile one. So it is the maximum cosmetic effect was given to her was this. So now the ugly looking effect was removed by neuroplastic surgery. This patient who was referred from neighboring country, he had a very bad head trauma, and he had a very bad looking fronto-orbital zygomatic defect, and the eyeball which was on the right side, if you compare to left side, was shifted down. Can you see here? So this eye movement was restricted. He couldn't move the eyeball all around because of the entrapment of orbital muscles. So now we can see here the bone was fractured and was shifted laterally, and the frontal defect was there. Orbital floor was totally gone. The orbital contents were going downwards. So as a teamwork, myself and my oculoplasty and facial-maxillary team did complete repair of this patient. This was the pre-op status of the patient. The defect was not corrected properly. So this is after immediately post-operative surgery. So we repaired the floor of the orbit, roof of the orbit, and also the frontal defect was also corrected. Now it is resulting in a very good cosmetic appearance to him. So now we can see the corrected mesh, which was almost navigation guided repair. This is the mesh which was contoured along the orbital rim, orbital floor, and also face was fixed with multiple implants. This is the immediate post-op. The patient was looking good and his eye was shifted above compared to previous situation. This is another complex situation where the patient was having a frontal tumor, which was involving inside the dura and also outside the dura. The skin was in, you can see there was a contrast enhancement of the skin. The skin was involved almost 6 to 7 centimeters. So we are confused how to sort out this problem. So we discussed with our plastic team, this is the tumor which was almost involving the entire skin. The skin was adherent to the bone. It was not free. So the diseased skin was planned to excise almost with the margin of 1 centimeter, because the inferiorly we cannot remove much because the orbital rim was very close to the tumor margin. So we are trying to remove as away from the tumor. Now the skin flap was rotated from the scalp, and it was planned with the occipital artery pedicle. Now the tumor was almost isolated. It was removed along with the bone, with the skin. Now the rotated flap was prepared for suturing with the remaining area. The skin scoring was done to make some extension and also to cover the almost 6 to 7 centimeter defect. This was the tumor along with the bone, with the skin. Now this is the patient. He had a very atypical meningioma. So now he's in radiotherapy. His cosmetic effect was not bad, even though we have removed 6 to 7 centimeters of skin. Once the radiotherapy is completed, we are planning to do 3D printed cranioplasty for it. Again, coming to bed sores, in chronic neurosurgical patients, the bed sores will become a very bad burden for us. It increases hospital stay, it lead to infection, it lead to a lot of medication consumption, and also it will delay the primary recovery of the illness. So also financial burden to the family. So now we are including bed sores in our neuroplastic work. So we are trying to prevent the bed sore. If it is not possible, so we are trying to address as quick as possible through our teamwork. One interesting story I want to share and conclude my talk. This is during my initial practice, a young guy who was fixed for marriage. He was traveling with the girl who was fixed for marriage in a week. They had an accident. The guy had multiple complex fracture in the face and also involving nose. Immediately after the accident, the girl just denied him to get married because of his complex facial injury. Then I called them because the family came to me. I called them and counseled them. Give me 6 months of time. If I'm making him all right, marry him. Otherwise, you take your own decision. I counseled the girl. The girl agreed for the deal. Then I took him for surgery, and that time we had frontal mesh with orbital reconstruction. This is the post-op period. So this is immediately after surgery. This is after 6 months. Then the girl agreed to marry him. Now they're living with 3 children. It was an interesting story of neuroplastic surgery. So I presented my work in WFNS 2013 in Seoul. That time I was proposing the fronto-orbital injury should be repaired primarily. So it was accepted as oral presentation. Then we were doing a lot of neuroplastic work in an unorganized manner. It was not organized to a specialty in our country. So I wrote a correspondence to Neurosurgical Review a few months back, a call for new neurosurgical subspecialty in Asian continent. Immediately I got a response from Iran by Hamadi, and he was also saying the same idea of mine. Then I discussed with Ben. So we are all trying to develop this program and this field in the world. So I'm trying to involve so many neurosurgeons around this world. So this is my team, Dr. Preeti Uday, oculoplastic surgeon, Dr. Anant Narayan, facial maxillary surgeon, Dr. Girish Ambat, plastic surgeon. Today, I've started a World Neuroplastic Surgery WhatsApp group. So all specialists who are passionate towards this field can join this group. We'll have continuous discussions and planning about treatment of neuroplastic work. And we'll take up this field to higher level from today. So I need 𝒂𝒂𝒊𝒏 Madam's blessings to take care of this specialty in Asia and also rest of the world. Thank you all. Thank you all for your attention. Thank you, Dr. Liu, for giving me this excellent opportunity.
This was a fantastic work and excellent demonstration of how really being passionate about not only removing the tumor, but also reconstructing the patient so they can go back to their normal life is a real ideal. I think that as neurosurgeons, we really focused our research efforts on the brain, rightfully for the last 100 years. And we, I think, missed the opportunity to think about the covering, the dura, the bone, the scalp, that make the patient whole again. And I'm so excited to see the amazing talk with all the beautiful pictures and how you take it into different directions, adults and pediatrics and trauma and tumors. And I think that we should all here listen and learn and push the field forward. And as you said, collaborate on a worldwide basis to basically not only guarantee patients are going to do better, but also to expand our skill set into other avenues. I think it's important to share those cases with our colleagues like the oculoplastics and the plastic surgeon and the ENT, and basically by learning from each other and sharing each other's skills, my feel is patients will get better outcome as you treat them as a whole. So thank you so much for this wonderful presentation, and I'm looking forward to continue this beautiful collaboration. Thank you.
Thank you, Dr. Nathibe.
Ben?
Yeah, so thank you so much, Professor, and I really enjoy your lecture so much. And I'm working on mainly on skull base, and I encountered several cases exactly like complex skull base tumor, exactly similar cases as in your PowerPoint, that we need to consider orbital accentuation and with skull base reconstruction. And subsequently, the experience that usually if we only use the rotational flap to cover the hold, and the wound might eventually dehisce. And very time we need to find our plastic surgeons for help. So my question is that in your experience for malignant skull-based tumor that you might need to give radiation. So would you reconstruct the skull base or the wound defect with the, for example, most likely would you require a free flap with the possibly by the plastic team. So would you reconstruct it after the radiation, and how long?
Yes. So actually, yes.
And another question is about, I also have some experience in doing the 3D printing for the cranioplasty. Sometimes the experience that is that the 3D printed cranioplasty may sometimes be oversized, because after the patient have the bone gone, the skin naturally will retract. So after you put back the bone flap, so you might encounter the difficulty in closing the wound because of the tension. So how would you solve this situation? Do you give for example, tissue expander for the scalp before the cranioplasty to make it, or you will design it during your cranioplasty? Yeah, thank you so much. And I really agree with you that neuroplastic is a specific field that we need to consider, because so often that we encounter this situation in our daily life, both in the skin condition and also the nerve conditions. And yeah, thank you so much.
So to answer your questions, the first one, If it is a malignant tumor, we are not doing any repair work. We are trying to close with the existing skin flap, either pedicle flap or rotation flap. If it is involving more than 6 or 7 centimeters, I showed you one case. The patient had 6 to 7 centimeter skin involvement. So we rotated the scalp and completed the flap cover. The bone was removed because the bone was involved in this situation. So what we'll do, we are subjecting the patient to radiotherapy. Once the patient was completely cured from the illness, then we are planning for next reconstructive work. That is the answer for first question. Second question, the 3D implants are designed by computer. It is only patient specific. So the problem is during the previous surgery, the muscles in between, for example, if you are doing a surgery in the frontotemporal region, the machine is calculating only bone. It is not calculating the muscle. So the temporalis muscle bulk is over the existing flap. What will happen? The metal will not fix exactly. So what I do, if you open the muscle and place the implant in between the muscle and the dura, it will fix exactly. But the problem is, if you open the muscle and fix the muscle inside, the muscle will not fix properly because the implant is lying in between. That will affect the mastication. So that is a major problem in this patient-specific implants. So nowadays, what I'll do, I'll fix just over the temporalis muscle. Second, there was a huge vacuum because the muscles will go for atrophy. It will be a atrophied area in between the implant and also skin. So we are few cases we have did fat graft in between to make, because we had one young girl, she was not married, the defect was very ugly, so we did fat graft inside the scalp and also just above the implant. Then she was having a very good cosmetic result and it was doing fine. So we are planning to do in more and more cases the fat grafts.
I see. So since Professor Ben-Salom is here, and also Professor, and about the neuroplastic, and because I have some interest in this field, because I also do complex skull-based tumor for reconstruction. So I would like to ask about opinion from both of you, that what is the role of neurosurgeons? How would you put forward the role of neurosurgeon in this special, unique field of neuroplastic? Because I think this is important but sometimes forgotten specialty in neurosurgery. So how do you stand the role? How do you see the role of neurosurgeon, and how can we distinguish ourselves from the oculoplastic and also the plastic surgeon? Yeah.
So listen, this is a great question, and I think that the more you do, I do complex skull-based and complex tumors myself, and the more that I feel confident fixing those patients before chemo and radiation, and let's say after chemo and radiation, the more I feel the unique skill set is not only of only a soft tissue coverage or complex reconstruction, but also a neurosurgeon. But it does take training, and I think that if you want to be this competent surgeon that can also can remove very complex skull-based tumor and then reconstruct the scalp and skull-based to prevent CSF leaks, and you need to spend this time of training, and you want to dedicate your part of career to that complex reconstruction. Why do I say that? Because if my patients, their wound break or fail after chemo radiation, I can treat that. I don't need to send it to the plastic surgeon for expanders or free flip. I know how to treat that. However, if I have complex orbital tumors that I would like a beautiful, complex reconstruction and approach, I would love to use my oculoplastic surgeon as much as you would use your ENT surgeons for the endonasal surgery. So I think there is a role for collaborations all the time. I think that as a neurosurgeon, if you want to be able to treat with your own problems, specifically coming to brain tumors and skull base, before to mitigate any risk for deformities and after chemo and radiation, you need to develop this extra skill set that take time and training. Right now there is only one place in the US that train neuroplastic surgeon, and this is at Johns Hopkins, where I was trained. It takes 1 year for training. What do you learn with this 1 year? You don't learn how to take out a tumor. You learn how to plan your approach and the reconstruction to the bone and the scalp to mitigate any risk, like we saw in the presentation before. So I think you really want to ask yourself, are you willing to dedicate much of your training and your skill set to the complex reconstruction as much as you want to dedicate it for that, let's say, skull-based tumors? I will say that we very much enjoy working with our colleagues, and we very much sharing multiple patients, and also our colleagues come to us for help. So I think it's a great opportunity to collaborate. But if you have this mindset to be able as a neurosurgeon to offer this complex reconstruction, soft and hard tissue, you are going to be exceptional and you're going to stand out compared to your colleagues of all fields. This is my personal opinion.
Thank you, ma'am. Maybe a business?
Kurbarma Sensei, thank you for the
Mama?
opportunity. Sensei, I have three questions, if you allow. First question, in Bangladesh, we have a huge number of trauma cases and also physical assault. So my question is, compound fracture of the frontal bone with multiple fragments, and when it is complicated with soil or mud, what is the treatment protocol in those cases if considering the reconstruction purpose?
The question is to me.
Yes.
I mean, what's your treatment protocol if there is a
Actually,
compound fracture
yeah.
and also it's been complicated with soil, grass, or mud? It's often we get this sort of cases.
Yeah, it's a very good question, because initially when I was doing multiple stage procedures, I had the same questions in my mind. So once I started doing primary reconstructions, we used to give thorough wash to the wound, and also we'll take care of the infection source, and also with very good cover of antibiotics. And we are doing primary reconstruction nowadays. We are not doing any secondary reconstruction. So with the team of oculoplasty, because most of the time it involves orbital roof or orbital floor or orbital lateral wall. So if it is not treated properly, definitely it will restrict the movement of eye. And also the fragment is inside the eyeball, it should be removed, because we had one patient who had a small chip of fracture which was almost touching the superior oblique muscle. He was having diplopia, but the fragment was very small. So what we did navigation assisted removal of the bone fragment. Then the diplopia was corrected. So similarly, we are doing primary fronto-orbital fascia corrections for almost more than 10 to 12 years. I stopped doing secondary correction nowadays, but it was giving a very good results, because you should give very clear, thorough wash to the wound, and you should give very good antibiotic cover, and also you should do all aseptic precautions.
Okay. Okay. Thank you, sir. Sir, one more question. What is your protocol in pediatric age group who underwent decompressive hemicraniectomy for the cranioplasty in pediatric age group?
Pediatric age group, we are not doing any patient specific implant, because the skull will grow automatically. So we had few patients we fixed with mesh. It is not a patient specific implant, because if you screw with the mesh, automatically the mesh will come out. So try to avoid any implants in growing skull. So automatically the skin will tear because of the growing skull, or the implant will pop off. So we had 2-3 failures. So now what I do, we'll try to preserve the patient's bone as much as possible. We'll try to give their own tissue cover, but we'll wait up to 13 to 14 years, because we had very bad AVMs which bled, and it was the bone was not replaceable. The bone is also very friable, so we cannot replace the bone immediately. Even if you replace the bone, sometimes the growing skull will form a new bone, and also it will form a cover. But if you are using implant in a very young age, definitely the skin will tear or the implant will come out.
Okay. Sir, just last questions. As we do bypass in Moya cases, a few of the cases are after taking out the STA, after harvesting the STA, in post-operative period, we have seen the ischemia of the
Yes.
skull. So, any tips you want to share
Yeah,
to avoid
actually,
this
we
situation?
had the similar problem. So what we are doing, we are taking fat from the thigh, and also filling the defect, which is having a very ugly looking defect in the skull. So that is giving a very good cosmetic result nowadays. Just we are taking like they are doing that liposuction, no? So we are removing the fat from the
Mm-hmm.
thigh, and slowly we'll inject in the area which is having the hollow in the temporal area. That is because of mainly muscular atrophy.
Mm-hmm.
So that is
Sure.
giving a good cosmetic appearance, but it does not give any functional result of temporalis muscle.
Okay. Sir, thank you, sir.
I think maybe we can invite Professor Alexander. So you have so many wounds, the patients.
Thank you. Thank you very much. Thank you. Professor Spodiswaran, thank you very much for a great lecture, great topic, and really it's a good idea, and I supported completely this idea. But from the other hand, I'd like to share my experience. Since a time of Russian invasion, we have been facing very, very difficult, complex cases of military injury. And it made it made me in my department, for example, separate like two neurosurgeons as a subspecialist, one for the peripheral nerve surgery and another one for the complex skull injuries. They go on their regular neurosurgical work, but they are a little bit specialized in that fields. From the other hand, these persons do not cover all the problems related with the complex cases. They are also like my people, my specialist for link for contact with the related specialists for ENT, for ophthalmologist, for head and neck, and so on, so on, so on. So what I mean, I think that's true that we should have a subspecialized neurosurgeons in our team, but from other hand, we cannot provide enough cases for their for their growing for their subspecialization. Anyway, we must be in good relation. We must cooperate with our related specialists, especially in more complex cases. So this is my way. This how was organized in my department during last years. Thank you very much. Really, thank you much for a very good idea and for great cases you presented to us. Thank you.
Thank you, sir. Thank you.
So, Raju?
Yeah, thank you. Thank you very much. Prof. Kodiswaran, a really impressive lecture. We
Thank
are
you.
we are amazed by such wonderful novel thoughts. Regarding our experience, I would like to share that you must be knowing Trivandrum Medical College is one of the largest centers that do decompressive craniectomies. Around 200 per year we do for traumatic brain injury as well as strokes and other things. So our experience is as regard to the compound depressed fracture. The first surgery is a damage control surgery. Okay, we take out everything which has been opened and exposed. There is a lot of dirt, everything. Just debride, take it out, and then whatever damage control is. The primary goal is to repair the dura. Okay, and on the second look surgery, we come back later during the time of reconstruction where cosmesis is the main factor. And again, as one of the discussions pointed out about the temporalis saving the STA, the STA never comes into this field. Like when we ever do a decompressive craniectomy, it is along with the muscle. We take the muscle skin, that it is a osteomyocutaneous flap. Okay, we take the muscle and skin together, so we do not damage the STA in anywhere. And regarding the replacement of bone flap, you said that you never use the temporalis cover. You lay it as an onlay graft
Yes.
over the temporalis. well, we have in our center done this study about laying the graft onlay and inlay, and as you mentioned, the main factor is the mastication. So we did a study that as we examined the masticatory force in these patients before and after cranioplasty with the onlay and inlay graft, and we found that there is much improvement in the masticatory forces post-operatively in both the techniques. Okay, in the same side as well as the opposite side also, there is improvement in that when we examine through a nathodynamometer, we have seen there is improvement. But cosmesis is one thing. Like when you lay it onlay and inlay, there is a marginal advantage of when you put it the temporalis over the graft. And there are several people who put a silicone like implant for the covering the temporalis halo during the cranioplasty. So these are things I would like to really thank you for bringing out this novel specialty thought together, and we hope I can contribute to this whenever in future.
No, I'm inviting you everyone. I'm inviting everyone to
Most
join
welcome.
this mission, because I'm taking up this mission because all neurosurgeons in the world should train in this specific field, because it's a basic simple ideas. It's not a very skillful techniques involved in this. It is only applying the common sense and what is best for the patient, what should be done immediately, what should be done later. So you should collaborate with people. For example, good quality people definitely will collaborate. So we'll, as Dr. Ben said, we'll learn from them. They'll teach us, they'll learn from us. So if we work together, ultimate benefit is going to the patient. If the patient is having good cosmetic effect, it is giving a lot of happiness to us. So the family is happy, we are also happy. So this should spread all over the world. I'm proposing this in this meeting because it should be taken over to all countries, because it doesn't need any high level training, it doesn't need any equipment, nothing.
Yes. Thank you. So Pirsad is waiting.
How much?
Please unmute your mic, Prof. We cannot hear you.
Thank you very much, Professor Kadisma, and greeting to all of our colleagues, especially Professor Kato. Konnichiwa. We have also some experience about war wounded during the Russian invasion and also internal war in Afghanistan. We have a lot of neurotrauma cases, war wound cases, and we are faced with scalp and also scalp and skull defect as well. And we use acrylic material, and also nowadays we use titanium mesh, but unfortunately the quality is very bad, and because we are important from neighboring countries, and also the price is expensive, and we are looking to find a way how to do, because we have a lot of scalp and skull defect as well. And we are also facing with some rejection and infection of the cranioplasty cases. And I would like to, in the future, share our experience from Afghanistan war with you and with our colleagues. Thank you very much. Thank you for your presentation, and excellent presentation, and congratulations for your achievement. Thank you.
Thank you.
Arigato.
Thank you. Dr. Ben?
And thank you so
Mikhail?
much.
One more?
Yeah,
Question for Mikhail?
Michael? Please unmute yourself. Yeah.
You are not audible, Michael.
Mikhail? So you can talk, please.
Okay. Thank you, thank you, Professor, for this excellent We have also some experience with traumatic brain injury and pediatric experience. From the traumatic brain injury, usually we don't have like 3D mesh and mesh. So what we do is we use the bone cement. So we reconstruct it manually intraoperatively and reconstruct most of the effective
Your voice is not clear, Michael. Dr. Michael, your voice is not clear.
Maybe Michael, you can type your question in the Q&A. That would be better because the audio is not clear.
Is it better?
Yes, better.
Okay.
Please
So,
try once again.
thank you both for this excellent talks. I have some experience in the pediatric and traumatic brain injury. So we don't have 3D mesh and titanium. So what we use is MMA, bone cement, and we will reconstruct it with manual remodeling of the bone cement. We have the shortage of plastic surgeon where I am working. So I don't have plastic surgeon. So whenever there is big defect, so I try to reconstruct rotational stuff, pediatrics and stuff. I have the few experience with one point in the labs. So my question now is do you decide lab quickly or how is your decision or how you look for it during this kind of stuff? So when the discussion leads to that, when you understand you have to clear
The question is not clear. We cannot understand.
Yes.
Yeah, it's not clear.
Yes.
Okay, so the question is, how do you decide in final exam of pediatric patient lab or patient?
But Michael, still we cannot hear clearly. So maybe
Maybe-
we'll send Dr. Raja. Maybe send him the doctor's email, please.
Okay, fine.
Okay, but you can listen, please.
Ben Sensei.
Okay, so maybe we proceed to our next webinars, and maybe shall I invite our chair again to introduce our next speakers, Xu. Thank you, Professor Vincent. Professor Ben Saloon. Yeah.
Thank you, Professor Yoko Kato and Professor Ben. It's my great honor to share our experience in the surgical resection combined with intraoperative radiotherapy for the treatment of brain metastasis. This work was led by Professor Xiaolei Chen, and we began this work just 2 months ago. So now we have done 7 cases, and today I will share the first case we done. Apart from what we have learned from the literature, we also do some new work to overcome some of the drawbacks of intraoperative radiotherapy. This is a 71-year-old female. The patient experienced memory loss without obvious cause 1 month ago. Her brain MRI examination revealed a space-occupying lesion in the right occipital lobe. She underwent right breast cancer resection 14 years ago, and the gene test results was unsure. Physical examination showed clear consciousness, fluent language, short-term memory loss, and she had left visual field defect in both eyes. This was her preoperative MR scan just on June 5th, 2024. We can see a large lesion located in the right occipital lobe with long T1 and obvious long T2 lesion, which means a large cystic part. This was a T2 flare image, and after this was a post-contrast image, we can see the lesion has two parts, the large cystic part and the console part. This was a coronal image, and this was a sagittal image. Her perimetry test shows unilateral visual field blindness in both eyes, which means that the tumor has damaged the radiac tract. So the diagnosis was right occipital lobe metastasis and postoperative breast cancer. The treatment plan we made was the new navigation and the intraoperative ultrasound-assisted right occipital lobe lesion resection and the intraoperative radiotherapy. This was a video of the surgery. Before we open the dura, we use the intraoperative ultrasound to to locate the tumor, which was high echo on the ultrasound. And after open the wall of the cystic lesion, we can remove the liquid and which will give us much room to resect the tumor. After enough separation the tumor from the normal brain tissue, we can remove the solid part of the tumor entirely. This was a surgery. During the surgery, we just use a coagulate and debulking the tumor before we remove it entirely. So we can see the blood supply of the tumor was extensive. We resect the tumor, use a relative border, which is the edema region between the tumor and the normal brain tissue. There is usually a obvious edema region for metastatic lesions. Okay, finally, we remove the tumor totally. After the removal of the tumor, we use the ultrasound, intraoperative ultrasound again to confirm that the tumor has been removed totally. Also, we use the intraoperative ultrasound to guide the process of radiation. So this is the intraoperative ultrasound image. This is the before the tumor was removed. We can see the tumor has very high echo, and which was obvious on the ultrasound. And the cystic part of the tumor was with low echo. This image was after tumor removal. We can see the tumor was removed totally, and there was no bleeding or hematoma in the surgery field. Intraoperative radiotherapy is a radiation therapy technique performed during the surgical process. Intraoperative radiotherapy has been revisited as a promising therapeutic approach since most malignant brain tumor usually means the high-grade gliomas and the brain metastasis recur near the original tumor site. This was the dose and the depth compared with conventional radiotherapy. The dose of the radiation lowered sharply in intraoperative radiotherapy, and the equipment we used was the Intrabeam 600. These were the applicators. We also called them radiation balls. They have different diameters generated from differentiated from 1.5 centimeter to 5.00 centimeters. The radiation dose we used in this case was 18 grays, and it was X-ray radiation. The applicator diameter was 2.5 centimeter, and the radiation time was about 15 minutes. To better monitor the process of placement of the applicator, we use the intraoperative ultrasound to monitor this process, which has not been reported in previous literatures. This was the process. Since the move of this machine is not very soft, and sometimes it may make extra damage to the normal brain tissue. So we do the process under the monitor of intraoperative ultrasound. We can say this was the applicator. It was monitored under ultrasound. This was a post-operative CT scan of this patient with no, we can say the tumor was removed totally, and there was about 1 to 2 milliliter hemorrhage around the tumor. This was her post-operative MR scan. We can say no hydrocephalus, and the tumor has been removed totally. Her post-operative pathology was low differentiated cancer and metastasis of breast cancer, and the estrogen receptor, progesterone receptor, and human epidermal growth factor receptor 2 was positive, which means this tumor was sensitive to chemotherapy. And this is also a reason why this patient got brain metastasis after more than 10 years resection of breast cancer. This was the patient's image at discharge. He has no new neurological deficits after surgery. This was discussion. About 13 to 14 of patients with systematic cancer get brain metastasis, and where brain metastasis is one of the main causes for decline of quality of life in cancer patients. Local brain control gains more and more importance since there are for many cancers, such as the breast cancer, the lung cancer, the chemotherapy has improved, got very great progress, and the patients can live longer, and the incidence of brain metastasis grows sharply. None of the current systematic therapies are sufficient to control brain metastasis. The overall treatment principle for patients with brain metastasis is to provide targeted treatment for brain metastasis based on systematic therapy, including multidisciplinary comprehensive treatment such as surgery, whole brain radiation therapy, stereotactic radiation therapy, and internal medicine. The aim to treat metastatic lesions, improve patients' symptoms and quality of life, and maximize patient survival time. For neurosurgeons, what we can do is to prolong the living time of patients and make patients not to die because brain tumors first. Whole brain radiation is associated with neurologic late toxicity. There are several advantages of intraoperative radiotherapy. First is the precision. The delivery of a precise dose of radiation to the tumor bed during surgery allows the delivery of a higher dose of radiation to the contiguous regions at highest risk of recurrence, while minimizing the dose to the normal brain tissue. Second is its efficiency. The biological effect of intraoperative radiotherapy is equivalent to 2.5 times that of divided external irradiation, decreasing the delay between surgery and adjuvant treatment. For traditional radiotherapy, the patient usually began the radiotherapy at about 2 to 4 weeks after surgery. During the intraoperative radiation, cancer cells, during the time between surgery and post-operative radiation, cancer cells may proliferate. The last but not the least advantage is safety. Through precise target localization, intraoperative radiotherapy can better protect surrounding normal tissue and reduce the occurrence of adverse reactions. Also, intraoperative radiation may got potential immunological benefits which has not been proved totally. Also, there is a great pinpoint of intraoperative radiation that during radiation therapy, all medical staff must leave the operation room and anesthesiologists cannot conveniently observe the monitor in real time to know patient's condition. This reduces the willingness of anesthesiologists to cooperate and perform the intraoperative radiotherapy. To overcome this pinpoint, Professor Xiaolei Chen developed this intraoperative multimodal mixed reality display system. With this system, the monitor and also maybe other images such as the video of the operation room can display on the head-mounted display system, which we can call it a mixed reality display system. We can see the monitor and we also can know the surrounding environment. This is the video of the intraoperative multimodal mixed reality display system. With this system, the anesthesiologist can know the patient's blood pressure, heartbeat, and all the vital signs of patients outside the intraoperation room. In previous literature, intraoperative radiation mainly now applied in neurosurgery for high-grade gliomas. Preliminary results from the integral phase 1 and phase 2 clinical trials indicated that intraoperative radiotherapy has good safety and can prolong the progress-free survival of patients prolonged about 3 months, and the overall survival for about 1.6 months of glioblastomas. The impact of intraoperative radiotherapy for prospective research on the survival of brain metastasis is currently lacking. This was an review published in 2024, summarized the intraoperative radiotherapy for high-grade gliomas, which got a conclusion that intraoperative radiotherapy may be a promising adjuvant treatment for selected patients with high-grade gliomas. From the previous literature and our experience, we think that intraoperative radiotherapy is a safe method to apply local brain radiotherapy for brain metastasis. And a very important point is that for patients with brain metastasis, if the patient receives intraoperative radiotherapy, the patients will not need to underwent the post-operative radiotherapy again, which usually has a larger amount of radiation. Intraoperative radiotherapy has steep dose gradient, low radiation protection efforts, and high relative biologic effectiveness. Intraoperative radiotherapy does not increase the perioperative complication rate. Local control rates are excellent for both high-grade gliomas and metastasis. Intraoperative radiotherapy does not hammer the start of a systematic treatment, which means after surgery, the patient can begin the chemotherapy or postoperative radiation for high-grade gliomas. They do not to lower the radiation dose. Intraoperative radiotherapy has potential immunological benefits which need further study. That's all. Thank you very much for your attention.
Ben, please.
Thank you so much, Professor Xu. And may I ask if there are any comments from the floor, or if not, then I will start my comment questions.
Yes, please.
Okay, so thank you so much, Professor Xu, and really interested in your lectures, and I also remember, and it's fascinating that you use Chen Xiaolei's the VR humanity. So it's very because I'm from Hong Kong, and I'm also aware of this and his breakthrough in the VR. So I have actually some question about the use of the intraoperative radiotherapy. I would like to ask about for the safety. So during the building of your operative theater, is there a dedicated unit that is a radiation shield to prevent the leakage of radiation? And second question about this is I can see that in your video. So when you put in when the machine put in the radiation source, still maybe the surgeons or assistant need to help during the procedure, because I remember I saw the hands in the field. So do they need to wear any protective covering to prevent radiation for the radiation safety? So yes, and my third question is about the dosage of the radiation. I can see that you use 18 gray, so it's I think it's slightly or similar to the stereotactic radiosurgery dosage. Is that the dosage that you use, and how do you measure or plan the isodance lines during your plan? Thank you so much, and really a great sharing of your experience in intraoperative radiosurgery.
Thank you for your question. For the first question, yes, there is a radiation shield in the operation room. However, the radiation shield is not very complicated. In our hospital, there was the operation room was designed for the orthopedics department. They do the spine surgery, and there may be the OB or the CB intraoperatively. So we use this operation room just to underwent a test which demonstrates that the radiation was safe for us to do the surgery. And for the second question, there was no radiation before all the staff get out of the operation room, and the process of make the applicator to the surgery field. The movement of the equipment of the machine was not very fluent. So we use the intraoperative ultrasound to monitor the process and to avoid some, for example, the intraoperative bleeding or hemorrhage. For the third question, according to the literature for high-grade gliomas, the recommended dosage is 20 to 30 gray. And for us, because this is the first case of our team, and we began this work just 2 months ago. The dosage was designed by the radiologist. It is not by us, and we do this work. It is a multidisciplinary work, not just by our neurosurgery, but also the Department of Radiotherapy. Thank you very much.
Thank you so much. 谢谢. May I ask any comments from our forum? Professor Olisen?
Yes, thank you. Thank you, Dr. Su. Thank you. Really intriguing, presentation. It's very interesting, but it stimulates a lot of different questions. And first question is, what are the particles you use for irradiation? Is it light or heavy? Or what kind of irradiation do you use from the source? Can you answer? It's a
X-ray.
X-ray, irregular
Yeah.
X-ray. Yeah. Oh,
Yeah.
so it means if you deliver 18 grays in one time, it's a very big dose for the brain. So we may expect the very deep brain necrosis during the procedure because the penetration will be very, very deep to the brain tissue, according to the classical irradiation. So it was very interesting to see the MRI after 1 week, after 1 month, and after 3 months after procedure for the patient, because I suppose you will have the quite a remarkable brain damage after this procedure, after this brachytherapy actually of the tumor.
Okay, we will do the follow-up continuous, and according to the literature, the depth of the radiation is about just about 5 millimeter.
That's all. But you know that there is a limit about 2 grays for one procedure. It's a recommendation of neuroradiologists. So maybe you use some very special spectrum for the irradiation. It doesn't damage the brain so much. So maybe. But so anyway, it's really interesting, and really I recommend you to collect more cases and to present them and to get basis to prove the prevalence of this method over the traditional method of irradiation after surgery. So thank you very much. Thank you.
Thank you very much. We will enroll more cases. Thank you very much.
Yeah, thank you.
Any comment from Professor Prasad? Please unmute yourself, Professor Prasad.
It's a wonderful idea and concept, Dr. Zhu. My question, what is the major advantage of doing this intra-radiation for METs compared to the conventional method? What's your idea behind this concept? It is exposing all the team who are operating inside, number one. Number two, for example, you need a lot of patients, and also it's a randomized controlled trial to compare the results of giving intra-radiation and also the conventional one.
Okay, thank you, Professor. For the first question, intraoperative radiation has been applied in many other departments, such as breast cancer, the liver cancer, and in other departments. And according to the literature, because brain metastasis was unlike the high-grade glioma, which means in high-grade gliomas, there are higher risk of recurrence in part maybe more far away than the brain metastasis. And according to the literature, for patients underwent intraoperative radiotherapy, postoperative radiotherapy was not obligated. And for the second question, yes, we have begun this work 2 months ago, and we have enrolled 7 cases with 3 brain metastases and 4 high-grade gliomas. In the near future, we will apply for the randomized control trial, and we will register in the clinical trials and to do better work, especially in the brain metastasis. For there has been no literature reported about the efficiency of intraoperative radiotherapy for brain metastasis. Thank you very much.
Thank you.
Professor Priestley, you have some comments? Sorry, Professor, please unmute yourself.
Excuse me. Thank you very much. It's a great presentation. Our experience for radiotherapy, we had before radiotherapy before the war in Afghanistan, but unfortunately during the war it's destroyed, and we haven't nowadays possibility of radiotherapy in Afghanistan, and it's a big challenge for our patients, and we hope with your help someday we have the possibility for radiotherapy in Afghanistan. Thank you. Arigato.
So if there are no any further comments, so shall we proceed with our third lectures? So our third lectures will be delivered with the pre-recorded video. But Professor Timo Kings was here. Hello, Professor Timo Kings. And Professor Timo Kings is one of the very prominent figures in the vascular surgery, and in both Canada and in the US. He's currently the professor and chief of the Neurovascular Center in 𝒂𝒏𝒔 Hospital in Boston, USA. And his topic today is the reservoir imaging in brain aging. And hello, Professor Timo Kings. He's with us now. So shall I play your pre-recorded video, or you want to present?
Yes, please play the pre-recorded one, because my internet is very spotty here.
Okay, sure.
Thank you.
Share the screen. Can you all see the screen now?
Yes.
Okay. So we will start the lectures by Professor Kings.
Sure. And in order to Professor Kato, dear Professor Ben-Shalom, dear discussants, thank you very much for giving me the opportunity to speak in the ACNS YNS webinar today to you about vessel wall imaging in brain AVMs. What I will try to convey today is that using these new types of imaging techniques, we are nowadays able to determine why certain brain AVMs form and actually rupture. And in order to say so, we will do a brief excursion before we talk about AVMs into the pathology of aneurysms. Because here we have known and identified that there is indeed a role of inflammation for the formation and rupture of brain aneurysms. This was first identified like more than 20 years ago where the Japanese group of Kataoka demonstrated that unruptured aneurysms had a different type of histology as compared to ruptured aneurysms. They found that in ruptured aneurysms, there were evidence for inflammation within the wall. Macrophages, metalloproteinases were present within the wall. However, this group was not yet able to demonstrate whether these inflammatory changes were present prior to the subarachnoid hemorrhage or were just the cause of the subarachnoid hemorrhage. It was 5 years later that the Helsinki group of Juha Niemi and Johanna Frösen was able to demonstrate that, in fact, the inflammatory changes that were present in ruptured aneurysms were preceding the rupture, because they could find out that the patients who came after a prolonged period in time had less inflammatory activity as those who actually came immediately after the rupture and where the aneurysm was harvested very early on, thus indicating that likely the rupture was preceded by inflammatory cells being present within the wall. There is indirect evidence for this theory that inflammation is an important factor for aneurysm rupture. And this indirect evidence was, for example, coming from the Dutch group of Gabriel Rinkel, who demonstrated that there are increased rates of subarachnoid hemorrhage after an influenza epidemic. And they argued that pro-inflammatory changes in the body actually predispose a patient to develop a subarachnoid hemorrhage. Something similar was found in the Framingham cohort. In the Framingham cohort, more than 20 or nearly 20,000 individuals were investigated for a prolonged period in time. And of those, there were a total of 95 who developed a subarachnoid hemorrhage. And these 95 participants who had developed at one point in time a subarachnoid hemorrhage all had a high leukocyte count at baseline, i.e., a pro-inflammatory condition within those individuals was predisposing them to develop an aneurysm and to have an aneurysm rupture. David Hassan looked at data from the ISUYA trial and identified that those patients who took anti-inflammatory medication, i.e. aspirin, had a lower likelihood of developing a subarachnoid hemorrhage as compared to those who never took any aspirin or like any anti-inflammatory treatments. Well, this is indirect evidence. What about direct evidence? Here, we'll talk about genetics and animal work and vessel wall imaging, which will then lead us to the AVM theory. Now, with gene expression profiling, this group here was able to identify that indeed macrophage-mediated inflammation is related to an upregulation of pro-inflammatory genes. In fact, they were able to find out that in the wall of ruptured aneurysms, genes that are pro-inflammatory are upregulated, whereas anti-inflammatory genes, such as the triple gene, were actually downregulated. Then we can do animal work where we induce aneurysms by injecting elastase into the subarachnoid space. Normally, these aneurysms form in mice after 6 days and rupture within 21 days. However, in knockout mice, where we have knocked out lymphocytes, these animals had significantly fewer aneurysm formations and aneurysm ruptures as compared to those mice that had normal normal lymphocytes. And we can go actually quite deep into the different pathways. This group here identified that a very specific inflammatory pathway is indeed present in patients with ruptured aneurysms. Vessel wall imaging can be used to image inflammation. Our group had demonstrated that ruptured aneurysm demonstrate significantly more enhancement as compared to unruptured aneurysm. Here's a patient with a single MCA aneurysm, but this patient here had bilateral PCOM aneurysms, but only the larger left-sided aneurysm demonstrated enhancement. The other one did not demonstrate enhancement, and this was therefore thought to be the rupture point. We can image also in unruptured aneurysms the inflammation, for example, in this case here, where we have dense enhancement within the wall of this MCA aneurysm. This patient was operated upon. We harvested the aneurysm and indeed were able to identify inflammatory changes within the wall of the aneurysm. And this has been shown by multiple groups here, the group from Guangzhou, Hongxi Sang, who demonstrated that wall enhancement is a predictor of instability of aneurysms. Now, what does this have to do with the preconceived conception that that aneurysms form due to the hemodynamic stress? Well, we have identified, again, our group here with Charles Matouk demonstrated that certain genes can be upregulated due to differences in shear stress. In this group, or here, we were able to show using like a combination of vessel wall imaging as well as computational fluid dynamics, that those aneurysms who have high shear stress forces, for example, this patient here, demonstrate significant amounts of enhancement, whereas those aneurysms that have low shear stress forces, for example, this or this one here, demonstrate no enhancement whatsoever. So therefore, and with this, I will stop about the aneurysms. Our current proposition is that hemodynamics may lead through the upregulation of pro-inflammatory genes in the aneurysm wall to a potential aneurysm rupture. And now the next step that we started on is, can we use the same type of thinking also for brain AVMs? Is it that in brain AVMs, the high flow shear stress forces lead to like pro-inflammatory changes within the vessel wall? And may this be the reason why some AVMs rupture? Well, let's have a look at a couple of ruptured AVMs, and they demonstrate some specific findings. For example, they often have significant edema very early on in the course of the hemorrhage. And this is not a reabsorption edema, because that takes 24 to 48 hours. This patient presented with an acute onset of headaches, and we see that there is already edema surrounding the bleed, which tells me that likely this edema was pre-existing. And where is the edema located? The edema is located surrounding a focal outpouching that we believe is the rupture point. Here is this focal outpouching pointing into the hemorrhagic cavity that we think is the rupture point. Here, another example where we have significant edema around the ruptured AVM, indicating that maybe the edema was pre-existing, and right there is a focal outpouching. Now, these are ruptured AVMs. Here is an unruptured AVM. But this unruptured AVM has edema, and we see a focal outpouching pointing into the region where we have the edema. Now, this patient's AVM looked like this 6 years ago. And now, by the time point where we have this MR, the AVM looks like this. And you see that in the AVM, in the inferior portion, this new outpouching with focal stasis and recirculation has formed, indicating that AVMs are plastic, they can change, and aneurysms or outpouchings can form within an AVM. We believe that these are the AVMs that are more vulnerable because A, they have a focal outpouching, a weak point, B, they have edema, and we have seen in the ruptured AVMs, outpouchings and edema. Here another example of an unruptured brain AVM. Again, we see the same thing. There's a focal outpouching here. We see it right here. So we did a microcatheter injection. And just at the transition from the artery to the vein, we have this focal outpouching, which we believe predisposes this patient for subsequent rupture. And this was embolized here before and after embolization, and then the rest was treated with gamma knife. And here's the same patient after the gamma knife treatment, and you can see that the AVM was cured. Okay, what about vessel wall imaging in AVMs? Here is a ruptured AVM, and we see the focal outpouching pointing into the hemorrhagic cavity. We believe that this is the culprit lesion. And guess what? Indeed, we were able to identify contrast enhancement in this outpouching, indicating, similar to the aneurysms, that there may be some inflammatory changes present within the wall. Now, let's have a look at vessel wall imaging in unruptured AVMs. And here we found that those AVMs that have perinidal edema, as seen here, often have focal outpouchings, and these outpouchings enhance, as we can see here. Or in this patient, where we have edema and an enhancing focal outpouching. Or in this patient, where we have edema and enhancement in the focal outpouching. But you see something else in these patients. There's not only edema, there are not only focal outpouchings, but there is focal thrombus formation. Look at this outpouching. The anterior portion, where there's no thrombus at all, does not demonstrate enhancement, and only the posterior portion, where we have, like the thrombus, demonstrates the enhancement. We are going back to this case here. We have the outpouching, and there's thrombus inside the outpouching. We have the outpouching here, and there's thrombus right there where the maximum enhancement is. Remember this patient? Yes, there is the outpouching, and there is focal thrombus right here where we have the enhancement. Or this patient where we have the edema and the local thrombus formation right here. And when I showed this to my predecessor, Karl 𝒂𝒏𝒔, he demonstrated and gave me a couple of additional cases that demonstrate exactly the same thing. Outpouching, thrombus, edema, unruptured AVM. Another unruptured AVM, outpouching with thrombus and edema. And so on and so forth. Here we have like this unenhanced CT, thick thrombus, very dense enhancement. Thrombus here and enhancement there. Here, a recent case of a patient who just presented with his first ever seizure, edema, thrombus formation here. Here is the thrombus within the focal outpouching. And all of these patients have the recirculation effect. And so what we are believing is that in these patients, the recirculation or stasis of contrast leads to thrombosis. The thrombosis prevents the oxygen that is in the vein to diffuse into the wall and therefore leads to wall hypoxemia, which will then lead to inflammation within the wall. And the inflammation in the wall can then lead to a breakdown of the blood-brain barrier, therefore the edema, matrix degradation, and therefore risk of rupture. Do all of the AVMs that we see rupture due to this mechanism? Likely not, but some, I believe, actually do. This now puts us one step further, where we are discussing now about why does thrombus actually cause inflammation? And what we believe is the potential interplay between thrombus and inflammation is through the NETs, or neutrophil extracellular traps. They have been found to be present in sterile thrombus when you have high shear stress forces, i.e. in those outpouches, there will be NETs, and these NETs will lead to degradation of the matrix of the wall, and therefore can lead to like rupture of an AVM. So the interplay between inflammation and thrombus is something that has been recently described as a potential mechanism of why we, for example, can have atherosclerotic plaques. Together with Johanna Froesen, our group demonstrated that indeed in AVMs, there is evidence for pro-inflammatory changes. We were able to demonstrate that a mediator of vessel remodeling and inflammation, i.e. 𝒀𝒏𝒔 ℒ2, is present within the wall or in the endothelium of brain AVMs that we harvested here. And we believe that this cyclooxygenase pathway may indeed be therefore a potential target in the future of treating brain AVMs, of treating unruptured brain AVMs, of maybe preventing the bleed of an unruptured brain AVM. So to conclude my talk, we are seeing currently a paradigm shift from flow-related hemorrhagic complications to biological changes in the wall of an AVM. And I believe that vessel wall imaging can help to identify those brain AVMs that are at a higher risk of rupture. With this, I would like to thank you once again for the kind invitation. I would be happy to take any questions. Here will be my email starting in October. I will move from Toronto to Boston, and I'm looking very much forward to this. Thank you very much.
Thank you, Professor King, for your very educational lectures. So maybe Professor Kato is here. Maybe shall I invite comment from Professor Kato about brain AVM vessel wall pathology?
Thank you very much, Timo. We are very much looking. Excellent talk. Thanks a lot. So just I want to know, because as I'm a aneurysm neurosurgeon, so I'm very much interested about vessel wall imaging. And you mentioned about outpouching. Is it only for the artery or sometimes the venous system? How do you think about it?
That's excellent question. So when you remember the case that I showed you where we did the microcatheter injection, this was at the end of the artery, at the arteriovenous transition. So I believe these outpouching, this is why I used the word outpouching over the word aneurysm, because aneurysm implies arterial. I believe that these are venous outpouchings. I believe that they are at the transition from the artery to the vein, because this is where the highest shear stress forces hit the weakest wall, because the venous wall is thinner than the arterial wall. So therefore, I believe it is likely that these intranidal aneurysms are just at the arteriovenous transition. They are therefore histological veins.
Okay, so thanks a lot. So that you mentioned about the three components. One is the thrombus and the edema and outpouching. So the ones we find the incidental AVM, so maybe it would better to have such kind of vessel wall imaging for prediction or protection for the bleeding. How does it? Thanks.
Yeah, and it may not only be necessary to have vessel wall imaging, but I believe if you have an unruptured AVM that demonstrates edema surrounding like the AVM, it means that there's disbalance between the brain and the AVM, and therefore like it may be related to venous congestion, it may be related indeed to inflammation. But whenever there's like this irritation of the brain by an unruptured AVM, we are more proactive with management.
Thanks so much. Thank you.
Thank you.
Ben?
Yes, may I ask a question, Professor? And thank you so much for this lecture. And I'm indeed very interested in this as well about the interplay. So I understand that from the aneurysm point of view that from the CFD models that the high shear stress test will lead to the inflammation. But how about my first question is about the formation, whether the CFD or the inflammation or the arterial wall enhancement will have any relationship with the formation of aneurysms and also the formation of the aneurysm, the role of the contrast, the role of MRI wall enhancement, where there is any relationship with the formation. Our second question is about the role of the CFD in the AVM. So because from the previous study, we talk about from the earlier part of the presentation, you mentioned about is the interplay between the hemodynamics with the CFD showing the high shear wall test and causing the inflammation. I know that in AVM, sometimes it's very complicated and difficult to generate the CFD. So, I understand your postulation that with this hemodynamics, with the high shear wall test, will probably causing the thrombosis and causing the inflammation in the edema and possibly the AVM rupture. So I think this is the message that I get. So how is there any updates or any suggestion of how can we study the hemodynamics inside the AVM? Yeah, thank you.
Excellent, excellent questions. Thank you very much. So for your first one, what we were able to demonstrate with the combination of CFD and vessel wall imaging is that indeed in the areas of high wall shear stresses, there is more enhancement. And we believe that this enhancement is related to inflammatory changes within the wall, i.e. a leaky endothelium. And the theory is that the shear stress forces can lead through epigenetic upregulation of pro-inflammatory genes and of an epigenetic downregulation of the anti-inflammatory genes, the cripple genes, for example, to this unstable vessel wall that will then demonstrate the enhancement. So this is how we see it for the brain aneurysms. And coming to your second point, this is exactly what makes it so difficult to use CFD in AVMs. AVMs are way more complex than an aneurysm. An aneurysm can be very easily modeled. You can segment the artery, you can segment the aneurysm proper, and then you can feed this into your computer and get your CFD results out. Whereas in a brain AVM, you have a tangle of abnormal vessels that will be extremely difficult to model. In addition, the shear stress forces in aneurysms will be different from those in brain AVMs depending on the flow rate. In aneurysms, there will always be an arterial flow rate, whereas in brain AVMs, depending on the shunting size, you will have high flow versus low flow, depending on the kind of arteriovenous transition. So you may have like very slow flowing AVM, you may have fistulous AVMs with a very high flow, and this will be difficult to enter into the model without like measuring actually the flow. And the final portion that I want to make is that the wall enhancement in aneurysms appears to be related to the fact that we have inflammation within the wall. But what we have seen in the AVMs is that the wall enhancement was present where local thrombus was forming. And so maybe we have here a different type of pathological mechanism that is related to local hypoxemia within the wall because the oxygen can no longer diffuse into the venous vessel wall, and therefore we'll have a degradation of the vessel not by means of inflammation, but by means of tissue necrosis. Both of which will, of course, in the end lead to metalloproteinases starting to digest the vessel wall and thus to the potential of a hemorrhage, both in the AVM and in an aneurysm. But their primary mechanism may be hypoxemia versus inflammation.
Understand. And thank you so much. It's indeed a very excellent, inspiring lecture for research. May I invite comments from our discussion, Professor Li Feng? Any comments from you?
Thank you, Professor Krings. Thank you for a really interesting presentation. It's a great idea, and I hope in the nearest future it will be implemented in practical medicine, especially for in acute cases, in chronic cases, and really, I have my comment is I really very satisfied that we will have another tool in the management of AVMs with our patients. So thank you very much. Thank you.
Thank you.
Any comment from Professor Fisher?
Thank you. Thank you very much, Professor. It was excellent presentation, and we hope we have it in the future and use your experience as well. Thank you.
Thank you very much.
Thank you so much. May I ask, are there any comments or questions from the forum? If not, any comments, final comments from Professor Kato?
Oh, yes, thank you so much. The three speakers told us so many very important things. The first, Professor Malapan, he mentioned about importance about the neuroplastic surgery area. I think it is really important. I think maybe we can have another webinar with you and your teams, I think.
We'll do that.
Yeah. And also intraoperative irradiation is a very new concept for all of us, I think. So maybe please accumulate here more cases, report again. And Timo, thank you very much for even your very hectic time. It was a very wonderful talk. I think many of us, maybe they have a great interest about the wall property itself. I think many of us are very interested to have the aneurysm walls, but the wall of the AVM is very new for all of us. I think it's a very important point. Thank you very much. We had a very great time. Thank you. Thanks so much.
Thank you. Thank you so much. So thank you so much, everyone. And on behalf of the educational community, I think it comes to an end of today's webinar. I'd like to thank our chair again, Professor Benjamin, for chairing this session. And we have we have speakers from different expertise, with Professor Kozwan talking about the neuroplastic surgery, and also Professor Xu talking about the intraoperative radiotherapy, and also last but not least, Professor Krings, who inspire us about the vessel wall imaging and the hemodynamics and AVM and aneurysm pathologies. So it's a fruitful day for all of us, and with many viewers on online as well. So I would like to thank you all of you for joining today's ACNS YNS webinar. This is very educational, and I hope to see you all in our next ACNS YNS webinar. So thank you so much, and it's a bye-bye to all of us. Thank you so much.
Thank you all. See you.
Thank you.
Thank you.
Okay. See you again.
Thank you, Ben.
Bye.
Good job.
Thank you.
Thank you,
Ben.
Ben. Thank you, madam.
Thank you.
Thanks. Thank you. See you. Thank you.
ありがとうございます。
Thank you.